myself, and it's an honor of both of us to be here. And yes, for the whole auditorium, colleague Prosh and I promise to be there live next year. These 30 minutes, I will speak about challenges in connective tissue disease-related ILD. Please stop me any moment, anyone in the auditorium. We will be interactive and ask any questions if needed. If this takes a little bit longer, don't worry, then I will make my case shorter later on. These are my disclosures. Concerning connective tissue disease and interstitial lung disease, the first challenge we have in hospitals is that we need a multidisciplinary team, and a multidisciplinary team that is really interacting. And I think today in the first lectures and afterwards with Laura and colleague Prosh and Simona, we will really interact how I think we should interact in daily life in our hospitals. Why do we need a multidisciplinary team? Well, interstitial lung disease encompasses a broad group of more than 200 parenchymal pulmonary disorders in which the lung tissue is comprised. We have several categories. We have the idiopathic, and I think we all know in the room idiopathic pulmonary fibrosis, which is mainly treated by pulmonologists and has an infast prognosis. We have the second category, and this is what we're interested in today, autoimmune-related ILD, in which you have some which may have an acute behavior, such as rapidly progressive interstitial lung disease, for example, an anti-MDF5 associated amyopathic dermatomyositis, or a diffuse alveolar hemorrhage in ANCA-associated vasculitis or in lupus. And you have some chronic autoimmune-related ILDs, such as connective tissue disease-associated interstitial lung disease, for example, in rheumatoid arthritis, or ANCA-associated vasculitis-related interstitial lung disease. There's also a category which we will hear about today, which is exposure-related ILD, and I think we all heard about hypersensitivity pneumonitis. And then you have some other categories, interstitial lung disease with cysts, sarcoidosis, or others. Depending on which category you belong to, management might be different. And we'll lead you through that today. The second challenge is that we need to create awareness in our peers that interstitial lung disease does exist. And I will show you one example where peers from another good peripheral hospital were not aware about connective tissue disease associated ILD. This is a story in a nutshell of a 58-year-old cook. He cooked in a Chinese restaurant. He had no relevant medical history. But in September 2022, he started coughing and had a mild fever. He went to a peripheral hospital with a very good department of pulmonology, but he was sent home. And about 2 weeks later, he presented at the same peripheral hospital at the emergency department with shortness of breath. And a chest CT was taken and a working hypothesis of a viral pneumonia was made, and he was sent home again. But within 1 week, he presented to the same peripheral hospital with a desaturation of only 30%. He was intubated and transferred to the university hospital. This was his HRCT upon transfer. In the university hospital, he was tested for autoimmune-related antibodies, and an anti-MDA5 was found. High-dose steroids and plasmapheresis were given, but unfortunately, the patient died due to respiratory failure. As Helmut is here, Helmut, can you just give us a comment on what you see here on the HRCT in 2 lines?
I think the problem here is nicely illustrated, that the findings we see in these connective tissue diseases closely resemble also diseases which has nothing to do with that. So in this case, I completely understand why the clinicians, why the radiologists in that hospital thought that this could be a viral disease. As we see primarily ground glass, very symmetric. This could well fit to a viral pneumonitis. So I think that illustrates what you nicely said already. We need to work together, because if you get more information as a radiologist, you then can also come up with other differentials, because viral pneumonia, particularly this time, is not that uncommon nowadays. So that we need to work together. And in addition to that, these viral pneumonias like COVID may also trigger the development of a systemic disease.
Thank you so much, Helmut. This patient at ICU also had extra pulmonary signals, such as dilated capillaries, and this is something which also gave us a hint. What about dermatopulmonary syndrome? Well, this occurs, as we all know as rheumatologists, in antisynthetase syndrome or MDA5 positive patients. But the big difference here is that if you have an anti-MDA5, that your prognosis is a lot worse. On this slide, you can see in the x-axis the days mentioned, and in the y-axis the probability of survival. And you see that patients with anti-MDA5 positivity have a far worse prognosis. In amyopathic MDA5 associated dermatopulmonary syndrome, the cutaneous manifestations are in the forefront. Our patient also had dilated capillaries on capillaroscopy, and usually contrast with the absence of clinical signs of myositis. Our 50-year-old cook also didn't have any myositis. We need to know that both in antisynthetase and amyopathic MDA5 dermatopulmonary syndromes, extrapulmonary manifestations might be lacking, hindering the differential diagnosis. And again, like Helmut correctly said, and he didn't know this case before, I tricked him because it's early in the morning, clinical presentation may mimic that of a bilateral pneumonia without microbiological documentation. So intensivists should consider inflammatory myopathies as a cause of acute respiratory failure, as in our cook, of unknown origin. Before we continue, I would like to canvas on what we are dealing with today. On this slide, you can see the big pie chart of interstitial lung disease. And as we mentioned earlier today, IPF comprises 12% of all interstitial lung diseases. And today, as Laura mentioned, we're dealing with connective tissue disease related interstitial lung disease. This comprises about 20% of all ILD. And then if you go within the connective tissue disease related, then you see the biggest chunk is made out of RA ILD, 39%, out of which 40% is progressive. The next biggest chunk is systemic sclerosis related ILD, out of which 32% is progressive. Now, why am I doing this intermezzo? Well, autoimmune interstitial lung disease with a progressive fibrosis displays similar characteristics to patients with IPF. And I will show you some clinical trials of IPF and the placebo arms of IPF. This is the impulsive trial in which nintedanib was tested in IPF patients. And here on the right-hand side, you can see the placebo group. These people lose more than 200 ml per year. Well, today, as Laura mentioned, we're dealing with connective tissue disease-related ILD. If these patients are progressive and are not treated, then this is the result. They lose 200 ml per year, so they do get worsening symptoms. They have a declining lung function, a deteriorating quality of life, and a high mortality, as in our IPF patients. I'll mention this for the first time today, but I'm sure you will hear a lot more. What are the criteria for progressive pulmonary fibrosis? Well, in a patient with ILD of known or unknown etiology, other than IPF, who has radiological evidence of pulmonary fibrosis, you have the definition of progressive pulmonary fibrosis when at least two of the following three criteria occur within the past year without an alternative explanation, and that's again why you need a multidisciplinary team to check if there's alternative explanations. But first of all, worsening respiratory symptoms. Secondly, physiological evidence of disease progression, defined as an absolute decline in FVC of 5% or more within 1 year, or an absolute decline in DLCO of 10% or more within 1 year. And then you need radiological evidence of disease progression, in which the radiologists, as Helmut will teach us today, help us a lot. Either you have an increased extent of traction bronchiectasis, or new ground glass opacity, or new fine reticulation. Either you have an increased extent or increased coarseness, new or increased honeycombing, and increased lobar volume loss. And I'm sure we will get some cases on that today. What are risk factors for ILD? And first of all, why it's important to know risk factors for ILD in autoimmune rheumatic diseases. Well, we've all seen that recently ACR has published guidelines on how to screen, and we'll mention this in a minute. We screen when there's risk factors, so we need to know our risk factors. In systemic sclerosis, it's being diffuse, being from African American ethnicity, history of smoking, being a male, an older age at disease onset, the presence of anti-topoisomerase, anti-SL70, the absence of anticentromere, having gastroesophageal reflux, a shorter disease duration, a higher skin score, and elevated CRP. In RA, the risk factors are again being male, it's always dangerous to be male, older age, history of smoking, elevated ACPA or RIMA factor, a longer disease duration, a higher disease activity, an elevated sedimentation, rheumatoid nodules, or MUC5B promoter variant. I know we don't test MUC5B in daily practice. A little bit later, I'll show you algorithms with or without the MUC5B promoter variant. In inflammatory myopathies, the risk factors for ILD are older age at diagnosis, arthritis, fever, anti-O, an elevated sedimentation, an anti-MDA5, and elevated CRP. This brings us to the third challenge in connective tissue disease related ILD. It needs to be recognized by the rheumatologist, it needs to be recognized by the pulmonologist, and we do need continuous interaction with the radiologist. In my university hospital, we meet every 2 weeks with the radiologist, pulmonologist, and rheumatologist in the ILD multidisciplinary team. And in the systemic sclerosis multidisciplinary team, we meet on a weekly basis. In fact, virtual as we do today. So recognition by the rheumatologist, what must we know? Well, as rheumatologists, we must know that the clinical presentation of ILD is highly heterogeneous and varies between patients. Patients present most commonly with insidious and progressive dyspnea on exertion and dry cough. At least this is what we find in literature, but patients may be asymptomatic. One of my patients with fastly evolving systemic sclerosis interstitial lung disease complained of not being able to do the household anymore, and that her husband told her she was lazy because she did less fast the household. So it's not always so clear-cut, but this is why it's important that we do screen our patients, and in a minute I will tell you how to screen our patients. What we also must know as rheumatologists that IPF, UIP is associated with progressive disease, but this is something mostly is done by pulmonologists, and we all know that IPF should be treated with antifibrotics, and if not, it leads to lung transplant or death within 3 years. But for us rheumatologists, it's important to know if we're dealing with connective tissue disease-related ILD or IPEF, because then we can treat them with immune suppressive therapy. So management is different. Importantly, that we know that connective tissue disease-related ILD or IPEF can take longer to manifest than IPF. Therefore, regular antibody serology testing and diagnostic review in the multidisciplinary team is important. The challenge is recognition by the pulmonologists. Pulmonologists need to know that ILD may sometimes precede systemic manifestations of RD. This means that if you have interstitial lung disease, sometimes only years later you get clinical symptoms of a connective tissue disease. And the pulmonologists need to know that ILD and connective tissue disease, even within one disease, may behave very heterogeneously. And therefore it needs to be discussed at the MTD. And in fact, a case that I will show later together with Helmut to you was a case of an SCL70 positive interstitial lung disease patient with systemic sclerosis who in the beginning had very minor changes on HRCT. And the pulmonologist in our multidisciplinary team in 2016 felt very safe about not immediately aggressively treating this patient, but this patient moved on very fast in the disease. But that's for later today. I just mentioned this to show again the importance of awareness, diagnostic testing, and of course the continuous MTD convening and interaction. And then thirdly, in our MTD, we need the radiologist. And I'll just superficially hint at a case that was discussed last week at our multidisciplinary ILD team. The pulmonologist from a peripheral hospital presented to us a case of 57-year-old, a case who had a severe scleromyositis in the past, but at this very moment was not active, CKs were normal, no activity on MRI of the muscles. 1 year ago, this patient had had a rectum carcinoma, and the serology of this patient was a Rho52, Rho60, and SSB. This patient was presented by the referral hospital to our multidisciplinary team because this patient had progressive dyspnea over the last year. And last year, this patient had an FVC of 90%, which had dropped to 87%. And last year, this patient had a DLC of 63%, which dropped to 38%. This patient was on low-dose steroids, and it was presented in the multidisciplinary team. And again, I will ask my colleague, Dr. Prosch, who is not with me and who's in Vienna, but I will ask him to help us on what we see here on HRCT. Helmut, is this a case like the first case I showed you with a rapidly progressive interstitial lung disease due to an MDA5, or what do you think this is?
This looks different. A very interesting case. We see that the lung density is increased. In fact, you see here, it's not so easy to appreciate that if you don't see the whole scan and if you're not used to see that. But this is too gray here, and I will show you later in my case descriptions then more about that. So this is what we call ground glass. In addition to that, you see some lines here, which we call septal lines. And then we see the cystic structures here and here. So diffuse ground glass, I always think about NSIB, which is the more common cause if it's chronic. But in this case, with the septal lines and the cysts, I would go for, as is written here already, lymphoid interstitial pneumonia, which is rare. But if you see that, we always think about Sjögren's.
Thank you so much, Helmut. So the radiologist last week, without knowing Helmut, nicely explained to us that this for the radiologist was a lymphocytic interstitial pneumonia. And then, as rheumatologists, we could say to the pulmonologist, dear pulmonologist, this patient also has a serology of a Sjögren, even though in the past this patient 20 years ago might have had a scleromyositis. We will now treat this patient as a Sjögren-related ILD and add on to your low-dose steroids, Celsat. So again, this shows us how much we need the radiologist in all our management. And this brings me to the fourth challenge in connective tissue disease-related ILD. We must screen of our patients with ARD. Dealing with systemic sclerosis, I'm spoiled because we do have guidelines, and in the systemic sclerosis community, as Simona and Laura taught all of you, we always screen all of our patients with an HRCT. So that's very easy in systemic sclerosis. If it's negative, we continue to monitor for ILD with regular lung function testing and history of checking for shortness of breath. And if it's positive, we check how severe our disease is based on lung function, exercise-induced blood oxygen desaturation, and clinical symptoms. As I said, I'm spoiled in this rare connective tissue disease, but what about the other connective tissue disease? Well, we do have guidelines. We do have guidelines from the ACR, which state that in autoimmune rheumatic diseases, which are systemic and are of interest, we screen if we have an increased risk for ILD. And this is why I said earlier today that you need to know your risk factors for ILD. Because if you have risk factors, you must screen with pulmonary function testing and high resolution CT. Something very strange happened. I don't know why, but I went to the end of my presentation. Let me check again where we are. We are here. So if your patient is at risk, we screen. RA was a difficult nut to crack until we got this very, very nice algorithm by the group of Schuger, which allow all of us rheumatologists in daily practice to screen our patients based on simple matter, based on disease activity score. We all collected DAS in our patient, based on sex, female or male, based on age, lower than 49, between 49 and 58 or more than 58, and based on the presence or absence of genotypes of MUC5B. Based on these factors, you can, through color codes, know if your patient is at high risk for RA-ILD. These are the red zones, or if your patient is at low risk. As we mentioned before, today we don't do regular testing of MUC5B. Well, this risk matrix also exists if you don't test for MUC5B. And then again, on easy parameters in daily practice, your DAS, your sex, and your age, you can classify your patient or not. So we have no more reasons as rheumatologists not to know when to screen our RA population. And this brings me to the last minutes of my lectures, the treatment of interstitial lung disease. As we mentioned already, IPF is something our pulmonologists do, and they treat with antifibrotics. What we're dealing with today is this big chunk of connective tissue disease-related ILD. And let me guide you through this. As I mentioned, the American College of Rheumatology gave us very nice guidelines. First-line therapy in our connective tissue disease-related ILD. Number 1 to treat is mycophenolate. Overall diseases. In systemic sclerosis, you have other options, tocilizumab, but it's not reimbursed in Belgium. Rituxan. In inflammatory myopathy, as preferred first-line therapies, you have number 1 mycophenolate, azathioprine, and Rituxan. In mixed connective tissue diseases, rheumatoid and Sjögren's, you have the same 3 top runners. Importantly, you may give in all connective tissue diseases, except in systemic sclerosis, a short term of steroids. In systemic sclerosis, as we all know, we have a strong recommendation against steroids. What if your patients progress? Well, if you progress, despite the therapies we just went over, you add or switch therapy. The therapy options in systemic sclerosis are, additionally to what I mentioned on last slide, nintedanib. And we know that from the ILD trial in which patients with progressive ILD got nintedanib and showed less progression. Or cyclophosphamide, or stem cell transplantation referral at an experienced center. Again, a strong recommendation against long-term steroids. The only moment I did add steroids in progressive ILD in systemic sclerosis patients is when there's a clear overlap with, for example, an anti-Yo antibody. Myositis. You may give, additionally to what we mentioned on last slide, calcineurin inhibitors, nintedanib, again based on the IMBL trial, IVIG or YAC, and YAC you can give with anti-MDA5 positive patients. We are against, the American College of Rheumatology is against long-term treatment with steroids. In mixed connective tissue disease, rheumatoid and Sjögren's, you can give mycophenolate, rituxan, nintedanib, tocilizumab, cyclophosphamide. Again, against long-term steroids. And in all of our connective tissue diseases, we may not forget in the multidisciplinary team to discuss referral for lung transplant evaluation at appropriate time for progressive disease. And lastly, if you're dealing with a patient who has rapidly progressive interstitial lung disease, if it's an MDA5 negative, you give IV steroids and one or two of the additional therapies, rituxan, cyclophosphamide, IVIG when you're afraid of infections, mycophenolate, calcineurin inhibitors, or YAC. When you have a rapidly progressive ILD, with anti-MDA5 positive, you give intravenous steroids and two of the additional therapies. With your multidisciplinary team, you consider early lung transplant referral. Having said this, I would like to conclude with the following slide. Interstitial lung disease is a diagnostic challenge to all of us. We need to create awareness in our peers. Multidisciplinary approach is something I cannot manage my patients without. So we do need continuous multidisciplinary approach with active teams which interact actively with each other. Rheumatologists, don't forget to check for ILD. Ask your patients if they're short of breath, use your stethoscope. Pulmonologists do think of an underlying autoimmune rheumatic disease, and we always need to ask the radiologist for help, as Helmut kindly gave to me during this presentation, even though he wasn't aware beforehand that I would do this. This is my local multidisciplinary team. In fact, this is my systemic sclerosis team with my patient centrally, my study coordinator, my pulmonologist, dermatologist, PED, clinical biologist, nephrologist, and nurses. I would like to thank you enormously for your attention. And again, Simona, enormously thank you for this invitation. I'm very happy to be here, and I'm ready to take any questions. Thank you so much for your attention.